site infection, prevention of surgical site infection. Objectives of this session to describe historical background, discuss the magnitude of the problem, list practical interventions. First, let's start with the historical background. You can see this is a surgical wound which is very infected. If we go back 200 years ago, 1813, Alice has an abdominal surgery. On the third day, she developed fever. At that time, they call it irritative fever. That was followed by purulent discharge from incision. Then she had what we call now sepsis, and she died. The main cause, it is obvious that it is related to this wound. It is infected and it led to sepsis. This is due to unsanitary condition. Now we call this surgical site infection. This was introduced by CDC in 1992. It replaced surgical wound infection. Now we call it surgical site infection. Louis Pasteur described microorganisms and their role in infection and wound infection. This is around in the mid 1850s. The first person to implement principle of antisepsis was Lister. Lister succeeded to reduce post-operative patient mortality to less than 15% in 1 year by implementing antisepsis. Surgical site infections are most common type of healthcare associated infection among surgical patients. They are the third most frequent reported healthcare associated infection. They represent 14 to 16% of such infection among hospitalized patients, 28% among surgical patients. Use of minimum invasive surgery reduce the incision and incidence of surgical site infection. Patients with surgical site infection are likely to require longer hospital stay. بيقعدوا فترة أطول في المستشفى. بيحتاجوا readmission sometime to manage their sepsis, or even if the wound care is very complicated or complex, and they are high risk of death. In addition, this will increase the cost and it reduces hospital revenue by occupying a bed to manage such infection. We go to this case study. Adam is a construction worker. While he was working, he had severe abdominal pain and he was taken to the emergency room, and they diagnosed him as acute surgical abdomen, and registrar decided to go for exploration. He go for laparotomy. So we want to look at him from infection control, prevention and control perspective. What are the best measures to reduce his surgical site infection? So this is Adam. He came from his work and he's dirty. He is a lot of dirt here. So it's a good clinical practice for patient to bath or shower prior to surgery, just using plain soap or microbial soap. ياخد له شاور وحمام 24 ساعة قبل العملية. It helped reduce surgical site infection. Adam took his shower and now he's going for laparotomy, and you found that he has a lot of hair. Should we shave or not? It is recommended that only hair that will interfere with the operation be removed. If hair removal is necessary, it should be removed by electrical clipper. يعني ما نستخدم الموس. Don't shave. No difference in surgical site infection among patients who have had hair removed prior to surgery and those who haven't. يعني إذا خليت الشعر أو شلته ده ما بيأثر في السيرجيكال سايت، لكن إذا الشعر بيأثر مع الجراح في الفيلد then it can be removed. وإذا هنشيله نشيله بالكليبر. Surgical site infection rate were shown to be higher in patients with hair removal by razor. Hair removal preferably performed immediately before surgery. دائما لو هنشيله نشيله بالكليبر ونشيله قبل العملية وما نشيله جوا غرفة العملية. shaving اللي هي بالموس is associated with formation of microscopic cuts in the skin that later act as foci for bacterial infection. والشعر طبعا نظافته صعبة، ما تشيل جوا الOR. طيب نقول الآن آدم أخذ شاور. القرار بتاع إزالة الشعر ده على الجراح. إذا if it interfere بالسيرجيكال فيد it could be removed. لو خليناه أو شلناه ما بأثر كتير، لكن لو شلناه ما نشيل بالموس، نشيل بالريزر أو الواكس. بتعمل في الأسسمنت حقك، اكتشفت أنه عنده نيمونيا. what is the impact؟ طيب إذا العملية طبعا هنا this is a laparotomy he has to go، لكن إذا كانت elective surgery thyroid or lipoma then this can be delayed or postponed. Treatment and remote infection. It is recommended to identify and treat infection remote to the surgical site before elective surgery. Whenever possible, all infection remote to surgical site should be identified and treated before elective operation. لكن في الامرجنسي you have to treat وتخش ما عندك حل. طيب اكتشفت انه ادم ده هو في الريكورد حقه he was colonized by Staphylococcus aureus. الامباكت حق الحكايه دي شنو؟ نشوف في السلايد الجايه. patient undergoing surgery especially خاشين cardiothoracic أو orthopedic surgery إذا كان they were known to have colonization nasal carriage for Staphylococcus aureus should receive perioperative intranasal application of mubricine 2% ointment with and without chlorhexidine wash. تعمل لهم الأوين ده بتاع الميوبريسين وخلال 24 ساعة ياخدوا شاور بالكلورهكسيدين. واحنا بنعيد في ادم اخذ الشاور. الجراح بيتخذ القرار في الشعر اذا في انفكشن should be treated، واذا في colonization تكلمنا عن الميوبريسين وعن الكلورهكسيدين شاور. لكن انا اكتشفت انه ادم ده السكر بتاعه 350. نفس الشيء اذا كانت emergency you need to lower and you take him to surgery. You lower quickly. If it is an elective surgery you can postpone this surgery. Usually we would like to have blood sugar between 140 to 180 اللي هي في الحدود بتاعت 150. Increase in blood glucose more than 200 in the immediate post-operative period have demonstrated to be associated with increased surgical site infection. Shall we give him perioperative prophylaxis؟ وإذا حنديها for how long؟ ونختار شنو؟ والمؤشرات اللي بنعتمد عليها شنو؟ تمام؟ وإذا الدرين قاعد هل ده بيتطلب انه زول ياخد مضادات لفترة اطول ولا لا؟ بنقسم الوونز لاربع كلاسز اللي هي كلاس 1 كلين سيرجري اللي هي زي الثايرويد واللايبوما، تمام. وبنسمي النوع الثاني كلين كونتامينيتد دي whenever you gonna open a mucous membrane، يعني لو هتفتح الباول الجينيتال تراك اليورينري تراك الريسبيراتوري تراك دي بنسميها كلين كونتامينيتد. انه هنا ده في كلين كونتامينيتد سيرجيكال بروسيجر اللي هي the respiratory elementary genital urinary tract is entered under control condition in the absence of unusual contamination. النوع الثالث class 3 include contaminated surgical wound which are accidental wound with major breach of asepsis or with leakage from gastrointestinal tract causing contamination in the absence of previous established infection. هنا بتبقى يتعرض لزي القط content دي هتقوم تعمل contamination. النوع الرابع اللي هو الانفكتد طبعا ده ابسيس وده باس وده should be treated اصلا ما في كلام. طيب it is recommended to administer antimicrobial prophylaxis within 1 hour before incision to maximize tissue concentration. إذا هنستخدم فانكومايسين أو فلوركوينولون ممكن نديها قبل ساعتين. يبقى الكلين سيرجري ما بنديها حاجة. الكلين كونتامينيتد بندي الانتيبيوتيك سنجل دوز قبل العملية بساعة، وفي الفانكومايسين والفلوركوينولون قبل ساعتين. أما الديرتي أو انفكتد دي you have to treat. For elective colorectal surgery بيستخدموا الميكانيكال باول بريباريشن ده بيساعد تقليل السيرجيكال سايت انفكشن، والسكين كير is very important. طيب don't prolong prophylaxis after completion of the operation for the purpose of to prevent surgical side infection. يعني في ناس بيدوا antibiotic at the time 1 hour or 2 hour قبل العملية، لكن بيواصلوا لفترة طويلة جدا. فهنا يا جماعة المواصلة دي it create resistance. It's not recommended to use any type of an advanced dressing over standard dressing on primarily closed surgical wound. إذا الدرين قاعد ده ما سبب أنك تواصل في البروفلاكسيس. remove the wound drain when clinically indicated. يعني هنطلع الدرين إذا ده بقرروا الجراحين. No evidence was found to allow making recommendation on optimum time of wound drain removal. ده قرار بتاخده الجراح حسب السيرجري والريسك اوف بليدنج او اذا اخدتيه لدرينج اوف اذر فلويد. من الحاجات المهمه الدكتور يعمل والستاف كله يعمل فيري جود سكرابينج، وده هنتكلم عنه في ستيشن مختلفه. Surgical hand preparation should be performed by scrubbing with either suitable antimicrobial soap and water using suitable alcohol base and rub before donning sterile gloves. ما ننسى بالذات في الإلكتيف سيرجري maintain good nutrition. don't discontinue immunosuppressive، ودي هنا دايما نخش في نقاش مع الروماتولوجيست أو النفرولوجيست. maintain during العملية والفترة اللي قبلها والبعديها good oxygenation, good perfusion and normothermia. في بعض الناس بيكونوا antibiotic في الوند. don't use antibiotic في الانسجن، ما عندها اي علاقة بانها تقلل لك السيرجيكال انفكشن سيرجيكال سايد انفكشن، بل بيزيد لك الريزيستنس. وفي النهاية shower bath before surgery. don't remove hair. hair removal as a discretion of the surgeon. treat remote infection, control blood sugar, treat colonization with staphylococcus, use prophylactic antibiotic for clean contaminated. اما الديري طبعا هدعالية. bowel preparation, maintain good nutritional status, good oxygenation, perfusion, proper surgical scrubbing, good skin preparation and dressing. Thank you very much. Thank you.